Good morning, everyone. Let's get started. Hello, my name is Ann Sasson, and I'm from Dartmouth Center for Global Health Equity. I'm pleased to welcome you to the Pandemic Partnership for Equity of Information's webinar. Today's session will focus on COVID-19 in maternal and neonatal care and will be led by Dr. Paul Palumbo. Dr. Paul Palumbo is a pediatric infectious disease specialist at Dartmouth Hitchcock Medical Center. Today's session will be recorded and shared online with all of you. A brief document summarizing the information will also be shared in English and in Spanish. If you have a question or comment, please insert it into the Q&A section. We are able to take questions in English, Spanish, and French today. Thank you, Dr. Palumbo, for joining us for this session.
Well, thank you, Anne, and welcome to everyone. We're really, as you all personally know, entering a sort of a new era of human history. It's been an interesting and challenging time, and I am so happy to be able to meet with you today through this method. Travel has been restricted, and I miss that. I miss interacting with international colleagues, so I'm very pleased to participate in this session today. We have a few slides that we'd like to share with you, and I can run through fairly quickly, but I'd really like to get through that and enter into a dialogue amongst all of us. I think we recognize there are no experts in COVID infection, or there are experts who are developing as we speak. So there's really communal knowledge that we all represent and can share. I personally be very interested in what's going on in your regions, where your challenges are, and what your approaches to those challenges might be. So today we're going to focus on pregnant women, mothers, and newborns. I come from a background of HIV care and research. And there are some potential parallels here. The caveat being that for COVID-19, we do not have a lot of data. In fact, it's a relative data-free zone. If we can move to the first slide, Anne, we have some session objectives here. We'll try to summarize the known risks of COVID-19 to pregnant mothers and fetuses. And I say known risks, but there are also hypothetical risks, which we still don't fully understand, and we're trying to get a better handle on over time. We'll also share some thoughts about infection prevention and control precautions in the maternal and neonatal setting. We'll describe some modifications to obstetrics and gynecological care during this pandemic. And we'll review some modifications to care of COVID-19 infected and COVID-19 exposed mothers and their neonates. So if we can move on, Anne, to the next slide. Great. So hypothetically, pregnant women are considered an at-risk population. We know that pregnant women have a more difficult clinical time with infections like influenza when they become infected during pregnancy. And so extrapolating from that model, we have some concerns that pregnant women may be at particular risk for COVID-19 infection. However, the current existing evidence does not suggest that pregnant women are at increased risk from COVID-19, so that the data we do have at hand suggests pregnant women experience similar symptoms and outcomes to non-pregnant women. There is limited evidence of an increased rate of adverse infant outcomes, but this evidence is weak, I would judge. We do think we're seeing a little bit more in the way of preterm births among mothers who test positive for this coronavirus during pregnancy. But The theme of a lot of what we're going to talk about today is that the data is extremely limited at the moment, and we make our best conjectures at this point. The other area of concern is vertical transmission, which is currently under investigation. There are limited case studies, primarily out of China, which, as you know, was the leading edge of this pandemic. They found no infants born to COVID-positive mothers who tested positive for SARS-CoV-2 or this COVID virus in the immediate newborn period. So no virologic evidence of in utero mother-to-child transmission. We also, in our guidelines, coronavirus infection is not an indication for early or immediate delivery unless there are maternal indications for that. Next slide, Ann. So moving on to infection prevention and control precautions in the peripartum arena. So we are cautious about COVID-19 in the face of limited information. Healthcare institutions in our country are advised to take as many precautions as possible to protect healthcare workers and to protect pregnant mothers, pregnant women, to prevent COVID-19 in the maternal healthcare setting. A lot of information is starting to come out of New York City, which is our biggest hotspot in the United States. They've instituted universal testing of all pregnant women that are admitted for delivery. To date, something in the range of 13 to 15% are positive for this coronavirus. And it's quite worrisome that most of these positive cases are in women who have no symptoms at all. So just screening pregnant women for who have symptoms will miss a large majority of infected pregnant women, at least in areas where the prevalence of this virus is high, like it is in New York City. I can say that in New Hampshire, where I live and work, we have a much less dense population. Our population is nowhere near as large as the New York City area, and we're not seeing near as much COVID-19 infection, and we are not routinely screening all pregnant women at this time. We are screening pregnant women who come from out of state, especially if they're coming from the New York City area, and we're seeing a fair number of those. What you're hearing is that we design our screening strategy based on local epidemiology. But where there are hotspots and where there are known high rates of COVID infection, consideration of screening all pregnant women should be made. And again, asymptomatic transmission and asymptomatic presentation is relatively common, which is a challenge to our management scenario. There's also a risk of transmission in individuals who are not symptomatic. So we know that for up to at least 3 days before the onset of symptoms, an individual can be infectious. So again, this poses additional challenges to our management strategies. Next slide, Ann. So, what general precautions for infection control might we consider? And again, this is going to be variable based on what's feasible, what resources are available locally, and what the epidemiology is in the region where the plans are being considered. One might consider screening patients before antenatal and postnatal visits. Um, this could be done via telephone or by outreach, where pregnant women, before scheduled appointments, go through a symptom screen and an exposure screen. Have they been exposed in a known or possible way? And do they have symptoms? If they have symptoms or known exposures, consider triage to determine whether they need to go to the emergency room and how they can continue to receive their treatments. So some upfront screening could be considered and might be helpful in infection control. Symptomatic patients should not be in non-COVID-19 healthcare settings. So we do triage and cohort COVID-19 infected individuals, whether they be in an outpatient clinical space or whether they be in hospital. So separation of care facilities, separate entrance, separate exit, should be considered if at all possible and feasible. The space that is carved out for care of infected individuals should have one patient at a time and should be fully cleaned between patients' arrival and departure. And all providers should be wearing proper personal protective equipment. And this has been a problem in our country in that supplies of PPE at times have been limiting. And so again, a little bit of a challenge, especially as the numbers of either suspect or known infected individuals increases. All patients and visitors who come to our healthcare facility are given a mask, a surgical mask if possible. Others can wear a cloth mask, and people in our country, and certainly in the state that I practice, have gotten very innovative in making their own masks. Some have very intricate designs and are interesting to see how they've evolved. Guidelines for the International Society of Ultrasound say that mothers during delivery do not need to wear a mask, as forced exhalations will be too strong to make the mask effective. So delivery is a risky period from the point of view of infection control. Next slide, please. So, in-office visits, what general precautions might we consider? And again, this needs to be adjusted based on local needs and local capabilities. Education of patients and family about this infection is important. Family members should be aware of any exposures, and they can self-monitor for symptoms. Limiting the number of people in the waiting room, stagger appointment times to minimize the number of patients in the waiting room and ensure distance between patients. This is an ideal consideration, not always fully possible, but you can see the theme of trying to protect and prevent person-to-person transmission. A no visitor policy. If allowing visitors should be systematically screened for symptoms and for exposure. Optimally, visitors should be tested. I can tell you we cannot do that at this point in our facilities, but we are getting to the point where our testing capacity will allow us to be more generally active in screening visitors to healthcare facilities, both outpatient and inpatient. Keep communal spaces clean. So hand sanitizer, tissues, trash cans, etc. In the earlier days of the pandemic here in the United States, hand sanitizer had vanished. You could not find or purchase it. It's become better, and we now have supplies. But simple things like cleanliness can face some limitations. Separation by about 6 feet has been the theme for chairs, beds, people using plastic or fabric screens to separate spaces is felt to be somewhat helpful. And finally, move routine testing to satellite clinics. So you can have dedicated regions for COVID-19 patients or persons who are considered under investigation versus general care settings where there is some confidence that COVID-19 is not present either as a risk or a known infection in individuals receiving care. Next slide, Ann. Thanks. So there are recommended prevention techniques. On the left-hand column, you can see the things, largely personal protective equipment that are recommended. Masks for patients and visitors. They should use at a minimum a cloth mask at all times while in a facility. Soap or alcohol hand rub to wash hands for 20 seconds. Good practice pretty much anytime. Use tissues to cover coughs and sneezes. Pretty common sense approach. And clean and disinfect surfaces and objects frequently. On the right-hand column, things to avoid: touching one's face, avoid close contact with others, avoid crowded spaces, avoid contact with anyone who has symptoms, especially respiratory symptoms and fever, and avoid sharing objects that touch your mouth like bottles and cups. Probably not bad advice most of the time. And avoid shaking hands. So we missed that physical contact. Hopefully someday we'll get back to this. But right now, it's probably prudent to avoid close physical contact, including shaking of hands. Okay, Ann, next slide, please. For staff, and I'll just lead off by saying I've been following a registry, a database in the United States, all pediatric intensive care units mostly in the US, but also Canada and Mexico, contribute data for the number of children and youth in pediatric intensive care units with COVID-19 infection. To date, there's about 300, so not huge numbers, but significant. So there's about 300 youth and children who have been or are currently in pediatric intensive care units. An interesting statistic that they also track is how many staff members in these pediatric ICUs are infected with COVID-19. So there are 300 youth and children with COVID-19 in our units. There are 100 staff who are known to be infected and around at home on home isolation. So for every 3 children in care in our pediatric ICUs, there's 1 staff member who is infected. So it can be a big problem. Staff should be regularly tested for this coronavirus. I must say that we're not testing staff. We test them for cause, but not on a regular screening basis at the moment because of test limitations. Staff should be screened daily, this says, and I think that's going to be very difficult to conduct until we have readily available rapid tests that are cost effective. Temperatures is another a way to screen, but as we've said before, there is this theme of a reasonable proportion of infected individuals are asymptomatic. So ideally, you'd want to do a viral screen if that's feasible. And as I mentioned, it's not always feasible. If a staff member has COVID-19 symptoms, they should not work. They should not be in the general healthcare facility. And if they test positive for the coronavirus, they should not work, and they should self-isolate for 14 days or be treated at the hospital depending on their symptoms. So we do have a subset of our healthcare workforce who are at home self-isolating for 14 days. And this can create challenges for staffing in the healthcare setting. Next slide, Ann. Other things that we can do, we can minimize the time of a patient visit. We can minimize the number of people coming in and out of patient rooms and try to minimize human interaction with patients as much as possible. One example would be to assign one nurse to work with each patient instead of having multiple nurses work with each patient. Next slide, Ann. So let's move on to OB/GYN care during this pandemic. So some things that we can do, basically change our standard medical practice by delaying non-essential activities, postponing elective or non-urgent visits, only have essential items in the delivery room to avoid contaminating stocked items. There have been a number of reports of contamination of hospital supplies, and they serve as a vector for transmission in that situation. So be a little bit careful. In addition to infection control, we have been chronically experiencing shortages of essential items. So it's another reason not to overstock the delivery room. We can replace as many in-clinic appointments as possible with telemedicine, which has become very popular for general care, for OB/GYN care, and for care of COVID-19 infected individuals. Next slide, Ian. So let's get a little bit into telehealth. Antenatal care, we can do home monitoring of obstetric factors like weight and blood pressure and blood sugar. Fetal heart rate can be monitored from a distance at home. Ultrasounds results can be communicated over the phone for general results. Certainly if there is major news such as anomalies or new diagnoses, that's nice to be able to do in person if possible. For labor and delivery, expectant mothers should receive COVID testing priority, and visitors should be limited. In postpartum care, lactation support and evaluation of cesarean wound healing or mastitis can be done through telemedicine via phone, pictures, or video. And just once again, telemedicine has increased probably at least an order of magnitude in this pandemic area, at least in our facilities. Next slide, Ann. So here is a chart of a plan for visits for care for a pregnant woman. And you can see in the middle horizontal line the depiction of traditional antenatal care, and just below it how we might consider changing antenatal care with telemedicine. And basically upwards of half of the visits are now being considered appropriate to conduct by telemedicine rather than in person. Okay, and next slide. So finally, and most interestingly in some respect, is what can we do regarding care for mothers who are either known infected or exposed and for their newborns? Next slide. So here we have some recommendations for PPE for healthcare workers. Delivery, whether it be C-section or vaginal delivery, is a time where we expect high risk for transmission, for aerosolization, for contact with infected secretions. An N95 respirator mask is considered important and indicated for almost all procedures that are listed on the left-hand column. Gown and gloves for all of these items. A medical mask, as opposed to the N95 respirator, could be considered for vaginal delivery by CDC recommendations. However, the Society of Maternal Fetal Medicine and the American Academy of Pediatrics recommend the N95 mask even for vaginal delivery. So we have a difference of guideline opinions between CDC and the AAP and the Maternal Fetal Medicine Society. And eye protection, some form of goggles or face shield for all of these conditions. Fairly extensive surgical approach for cesarean and vaginal deliveries. Next slide, Anne. So, labor and delivery precautions. So C-section, cesarean delivery, should be performed in an operating room with negative pressure if the woman is suspected or confirmed to have COVID-19 infection. If that isn't possible, consider conducting the delivery in a separate room. For women with known COVID-19 infection or who are under investigation, we would certainly recommend avoid delaying cord clamping, which is a reasonably common general practice. This is to try and prevent infection via blood being transmitted, and or to avoid delaying the time in the special healthcare facility. Any placental tissue, miscarried embryos or fetuses should be treated as infectious tissues and disposed of or cared for appropriately. If possible, routine pathologic examinations should be encouraged, and investigation of the presence of the virus by quantitative RT-PCR should be undertaken. I must say this is not common to be done, but it would provide a lot of useful information if we could do this on a more regular basis. Next slide, Ann. So this gets to be a little controversial, but in the United States, we've been pretty aggressive about separating or strongly recommending separation of newborns at birth from their mothers. And these are mothers who have either known coronavirus infection or who are being tested for it because of a heightened concern because of exposure or symptoms. We recommend admitting an infant to an area separate from other unaffected infants, and providers should wear PPE for newborn care. If an infant cannot be separated for any of a number of reasons, we try to maintain some separation of the infant from the mother. Curtains or plexiglass shield can be useful in facilitating this. Next slide, please. We also have been recommending testing infants born to mothers with COVID-19 or suspected of COVID-19, we test them at about 24 hours of age, and we often will recommend repeat testing at 48 hours after birth. This is reminiscent of practices in similarly for herpes simplex in mothers, where we will surface culture infants starting at about 24 hours of age to try and detect exposure and or infection. If the infant is at risk for exposure and not able to be tested, frequent outpatient follow-up is critical via telehealth or in person for about 14 days. These are our best recommendations at the moment, and as more data comes in, I strongly suspect some of these recommendations will be adjusted. If ongoing hospital care is needed, COVID-19 positive mothers should maintain separation until they're afebrile for 72 hours, until they have improved respiratory symptoms, and importantly, if possible, to try and get 2 consecutive negative COVID-19 tests collected a day apart. Again, these are what we feel are best practices now. There is limited concrete objective support for some of these recommendations, but these are our best hypothetical approaches at the moment, recognizing that it's not always possible to implement all of these recommendations. Next slide, please. So this is a very interesting slide because it shows the wide variety of recommendations out there for breastfeeding and rooming of mother-newborn pairs. In the left-hand column, these are rooming recommendations. In the middle column, breastfeeding recommendations. And in the far right column are where the recommendations are coming from. And as you can see, we have WHO recommendations, US CDC recommendations, American College of OBGYN recommendations, some out of China, some out of Canada, and there is considerable variability from expert organizations. So again, I see that it's going to be important for us in the United States and for all of you in other regions of the world to put together your best approaches based on feasibility and current knowledge. This can be challenging because feasibility is a real issue and knowledge is limited. So as far as rooming goes, mother and infants can share a room, according to the WHO. Hand washing and masks should be used when available. The WHO feels that breastfeeding should be permitted, but the mother should wash hands and breasts and wear a mask. So reasonably liberal by the WHO when making recommendations to the global community. When you move to the US, you see things get much more conservative. We are recommending temporary separation of mother and infants. Of course, weighing the benefits and risks of that separation. And we don't know how long the separation should be maintained. When one goes to breastfeeding, direct breastfeeding is allowed or at least recommended. Expression of breast milk and administering via bottle is another approach that is considered and is coming out of ACOG or the American College of OBGYN. There is another option of mother's choice, leaving the decision to the mother in consultation with her care providers. The most aggressive approach is full separation of mother and newborn with no breastfeeding or breast milk feeding. So that's the most severe limitation recommendations. And then in Canada, they're recommending neonates should be isolated until the infant has been well for 10 days or until the mother's period of isolation is complete, and they are discouraging breastfeeding. So we have a range of recommendations from expert organizations, which we have to try and navigate and use to try and adjust or develop a standard approach in the regions where we live. And this is a constantly evolving process. I've been participating in the peripartum recommendations for our facility. And I can tell you in the earlier days, I would say 5 or 6 weeks ago, we had daily meetings and daily adjustments to our recommendations. That has slowed down as far as frequency, but literally on a weekly basis, recommendations are reconsidered based on new information that may be coming forth. Do we have another slide, Ann? Yes. So, summary. Pregnant women are considered an at-risk population, but the COVID-19 specific data is limited. What we do have suggests no increased risk to pregnant women in the way of COVID-19 infection. Infection prevention and control precautions can reduce asymptomatic and pre-symptomatic transmission during antenatal, during delivery, and during postnatal care. Having said that, there are challenges with infection prevention and control precautions, especially in the form of the presence of asymptomatic infection during which transmission is possible. Delaying non-essential visits and implementing telemedicine as much as possible is likely to help with infection control. And care of COVID-19 infected mothers and both infected and exposed mothers and their neonates requires a fair amount of personal protective equipment and consideration of some forms of separation between infected mothers and their neonates. So, Ann, I believe that gets us through the slides. Is there anything else? No. Okay.
I'd like to invite our participants to ask questions or to share your comments with Dr. Palumbo. You can share your questions through the Q&A or through the chat feature.
And another option is to see if any regional representatives would be willing to share their experiences, what's going on with COVID-19, where their challenges are, and what their strategies have been to provide care for pregnant women and newborns.
Do we have anyone on the line who'd like to share? I have a question from the audience. Besides having mothers implement infection prevention protocols, is there anything else that should be done to protect neonates and babies under 1 year of age? Were you able to hear that question?
You're referring to me, I assume?
Yes.
Yeah, okay. I'm just reading it now. Interestingly, in pediatrics, especially in the younger group, let's say from birth to 5 years, we've noticed some very interesting data that is young children and babies are underrepresented in our data of COVID-19 infection. Some of that is because they're not tested as frequently, but even among those that are tested, infection rates are very low, especially symptomatic infection rates. So many of us believe there's some very interesting biology occurring in the pediatric age range that seems to be protective, at least of symptomatic infection to some degree. We don't understand the underlying mechanisms of that. And as antibody testing is rolled out, we'll get a better feel for the epidemiology of the infection across our populations. And from my vantage point, it'll be particularly interesting to see what's going on with children. Are they getting infected and just remaining asymptomatic? Are they experiencing much less infection than the general population? These are all big questions that need to be answered. We have some hints, but we really need some solid data.
I have another question. What about heparin prophylaxis among pregnant women with COVID-19?
So I have not heard of formalizing heparin prophylaxis. We have heard of in the non-pregnant population, we have heard of hypercoagulable states and increase in blood clotting as a complication. Whether this is occurring with any frequency in pregnant women, I have not seen data. And I have not seen general recommendations for heparin. Is that consistent with what our participants are seeing in their regions?
I have a couple of questions asking about mothers considering delivery at home and some of the risks associated with going to a hospital versus delivering at home.
Yeah, that's a tough one. I can tell you our local experience. We live in a relatively rural area in northern New England. We're not that far from New York City, where there's a massive outbreak of COVID-19, and we've seen a fair number of pregnant women travel up to our healthcare facilities away from the hotspots to have to conduct their deliveries. So we have seen movement away from the home base if the home base is a hotspot for COVID-19 infection. Most facilities, if they are doing screening of all patients coming into the healthcare facility or into the labor and delivery suite, I would consider that fairly safe environment where patients are separated based on COVID-19 infection. But if screening isn't occurring and you're in a relative hotspot as far as prevalence of COVID-19, then there are some hypothetical risks of going to a healthcare facility that's caring for many infected patients. It's hard to answer this question with any confidence because the data is limiting. And so you're weighing the risks of delivering at home versus delivering in a more sophisticated healthcare facility, where that healthcare facility comes with some risk of being exposed to COVID-19. So it's a delicate risk-benefit decision, and I suspect weighing that in your local region is going to be important based on what's going on in your healthcare facility and what's going on in your community regarding the prevalence of COVID-19 infection.
I have another question asking if there are clinical trials for pregnant women or kids that are underway.
So I would assume you're talking about treatment trials. And I am not aware of any treatment trials for children under 12 years of age or for pregnant women. I think those will be needed. Right now, we're seeing treatment trials that are targeting adults and teenagers. You've probably heard of the Gilead drug remdesivir, which just made the news in the last 24 hours with some promising results with a study that was sponsored by the National Institutes of Health here. Those trials are open to individuals 12 years of age and older, but pregnancy is a contraindication. So for the youngest pediatric group that is under 12 and for pregnant women, we don't have data for any of the interventions that I'm aware of. With time, we may start to develop that data. I think it'll be important. But at the moment, to my knowledge, there's no trials targeting either younger children or pregnant women.
I have another follow-up question about the conservation of PPE. Someone is asking what you would advise in settings where PPE is extremely constrained. How would you prioritize the use of PPE in the maternal health setting?
Yeah, that's a good one. We have taken to, for our N95 masks, we have taken to sterilizing them between use, and our facility can get 20 sequential uses out of a single mask at this point in time. So that's one option. But if you have limited supplies, you need to prioritize them for the highest risk settings. So certainly for individuals with COVID-19 infection, I would certainly protect staff and prevent person-to-person transmission by using PPE comprehensively. For newborns, I think the separation part is reasonable to consider. Do you need to wear PPE for the care of those newborns? The data on newborn positivity suggests it's very low. So that might be an area that you could cut corners if you have very limited supplies. But we've taken, even with limited supplies, to recommending and using PPE for pregnant mothers or postpartum mothers who are known to have COVID-19 and for their newborns.
Do we have any other questions? Dr. Palumbo, can you comment on when we can expect to have data on risks of exposure to neonates early in pregnancy?
Well, there are a proliferation of registries out there. In the United States, there's a peripartum, prepartum, postpartum, peripartum registry for pregnancy and for newborns that many sites in the United States are contributing to. Our Center for Disease Control is coordinating data gathering, again, in the same area. I'm not aware of prospective studies being done that enrolls all pregnant women. Those might be out there, but I'm not aware of any. So when might we get the data? I would think over the next weeks to months, we will slowly see information in the form of publications or broadcasts about data that emanates from such collection mechanisms.
Do we have any additional questions before we conclude our session? I'm not seeing any additional questions. So Dr. Palumbo, I'd like to thank you for joining us today. I'd like to thank all of our participants for joining as well. We'll have another session next Thursday at 8 a.m. Eastern time. Again, we are looking forward to hearing from you with feedback on this session, as well as other topics you'd like us to cover or other ways that we can support you with your work. Thanks everyone for coming together this morning.
Thanks, everyone.